a long time. So this one is
Miss Beaver?
Yes.
Do you want a record, please?
Do what? Yeah. Oh, yeah. Thank you so much, because I keep forgetting to do that because I'm afraid that it's going to. Okay, I'm gonna have to go back to stop share and record, because the records. There it is. They keep changing where they put it. Okay. All right. So we are on our record, and thank you, Abear. I appreciate that, because I just get going with what I'm thinking about, and then I forget the recording. So, all right, let me go back to our share screen thing. There we go. Can y'all see?
Yes.
Okay, good. All right. So our clinical manifestations, these are general. It disrupts function of your body. Lots of parts could be having problems with function, from obstruction or pressure, for example. And then the hematologic alterations, they impair normal function of the blood cells in a lot of cases. And infection, there's definitely a risk for infection because of that invasion. And if you're connecting to organs like the rectum and the bladder, that can be an issue, because we got that E. coli in there, and so the bladder could just, it could go all the way back up to your kidneys and cause the pyelonephritis, and necrotic tissue can the bacteria, if there's any bacteria in the area, then they're going to be just multiplying and multiplying and multiplying. So, and it can impair the immune response, but you may already have an impaired immune response that causes you to have cancer too. So it kind of goes both ways. It's kind of, it's a cruel thing. So, liver function can be disrupted, and nutritional and hormonal and hematologic and immunologic problems that can be life-threatening. And your liver's responsible for your metabolism. And then especially though, I mean, that's the main metabolic functioning. And the pressure can cause portal hypertension, and that means the blood vessels in the liver are going to be swollen, and they may stretch, and if they can't stretch, it's going to just be very tight there, and it's going to cause hypertension in those vessels, those specific liver vessels. And that can result in ascites and varices. And I guess, I don't know that y'all have studied the liver. You hadn't had the liver unit yet. I think that's in 114 maybe, but so y'all wouldn't have had that part. But the ascites is if you've got all of that pressure in those blood vessels in the liver, it's all the pressure is sending the fluid in the bloodstream out into the tissues, or out into, especially with ascites, it's into the abdominal cavity. And then the varices is when you have, if you have that portal hypertension, it influences the esophageal vessels. And then when the esophageal vessels start getting really, really tightly filled with fluid also, it can cause problems. It's not necessarily like an ascites thing. It's not going to actually go out. It's not a very big area. It's not a cavity. So it's going to be really, really tight and have lots of pressure in it. And people can die from having a hemorrhage from the esophageal varices, because there's so much pressure in there, and it's gotten stretched. The vessels have gotten stretched so much that they become weak, and then it just blows the gasket kind of, and it just blows, and you can just bleed to death. People can just vomit, have vomiting. My dad had some bleeding like that. when right before he died, he had hepatocellular cancer, so he had the esophageal varices to some degree, and so yeah, he had some vomiting up blood, but that didn't take him away at that particular point, but he did have some vomiting out blood. So anyway, impaired function of the blood cells can be due to the production of great numbers of immature white blood cells in the leukemia, because you got a whole lot of white blood cells, but they can't do anything. They're just in the way, and they need to be destroyed. So that certainly doesn't protect immunity. And then overcrowding in the bone marrow from excess white blood cell production, and it can greatly decrease production of those normal numbers of red blood cells and platelets, because there's the signal that's wrong. The signal says to make these specific leukocytes that can be different types. It can be neutrophils. It can be eosinophils, all kinds of things like that. But anyway, white blood cells, lymphocytes, they can start really producing and just packing the bone marrow. So there's no room to make the red blood cells, or very little room anyway, and the platelets. So yeah, that's a big problem, and we'll talk about that we'll have a leukemia unit in 211. So anyway, if you don't have the red blood cells and platelets, you can have an anemia and clotting problems, of course, and GI tumors can prevent absorption of the vitamin B12 and the iron. We just talked about that on our first day of this unit, and so you need the B12 and iron for red blood cell production. Of course, folic acid too. There's a lot of other stuff, but those are the main examples. And tumors rob the bone marrow of those building blocks for the proteins, like the purines and the folate that are parts of the DNA, and that compromises that normal blood cell production. So you can have the infections like that, what I just said, the bladder and bowel fistula. It increases a risk for severe and continuous urinary tract infections. And the necrotic tissue within the tumor can become infected, and the immune tissues or the organs are involved with the tumor they may result in impaired immunity. If it is like in lymph nodes, if you're having like a lymphoma, or a type of leukemia that involves the lymph nodes and the lymphatic vessels. So you can have brain or nerve involvement, and it can alter your sensory and motor and cognitive functions. And that's what happened to my next door neighbor. She died from adenocarcinoma of the lung, and that's the one that's not necessarily associated with smoking. And so she was not a smoker or anything. I don't know why she had that. I think somebody's got their mic on. Can y'all mute your mic? Because I'm hearing some clickety clacking. Can you do that? Okay. Yeah, I don't know. I can't see who's got what, but anyway, thank you. All right. So we can go to some more manifestations here. Hemorrhage, that's what I've mentioned about the blood vessels in the esophagus, and that you can bleed to death that way. And you can have anemia, or you can have it can go to hypovolemic shock. That means you don't have enough blood or fluid or pressure in your blood vessels, and so you go into shock. It's really a collapse of your blood vessels. So anorexia and cachexia syndrome. Cachexia, I don't know if y'all have known that word, but you know about anorexia, that you just don't want to eat, or you're not hungry and all that. But you can be just not hungry because things don't taste good. Sometimes there's the chemicals that the tumors put out in your bloodstream make your taste sensation the sensory areas in your tongue and all that. It can really mess it up, and you just don't want to eat. You may be hungry, but you don't want to eat because it tastes horrible. And so, but then the other thing is the cachexia part is where, and I know this sounds so horrible, but like when I went to Dachau when I was that's in Germany. It was a concentration camp, and they had a museum about that. And I've also gone to the Holocaust Museum in Washington, D.C. also, and it has all these horrible pictures of just these piled up bodies that are only they've only got bones and skin tightly over the bones. I mean, it's just like a pile of people that they're going to dig a hole, or they're going to put them in the like the cremation area where they just go on and keep burning them and burning them and burning them. But anyway, this that's just my vision of this, and you can see. I think there's some pictures in your book about cachexia. I'm pretty sure that I don't have my book with me right now, but anyway, it makes you just waste away. And what happens is that when you have when you don't have enough nutrients in your normal tissues, what's happening is sometimes when we talked about angiogenesis, that you're making, or the tumors or tumor cells are making their own or they're creating their own blood vessel system, and they're very fragile, and they're leaky. Things, it sort of leaks out. It is not really greatly functional, but it does shunt away the nutrients. If the patient, sometimes the patient is eating well, but when that angiogenesis happens, and the tumor's blood vessels takes all the nutrition away from the normal cellular areas, or the normal blood vessels, then you just waste away, because it's in your body, but it's only feeding the tumors, or mainly feeding the tumors. So that's what cachexia can be. It's not anorexia. It's a bad thing, like anorexia nervosa, that's a different kind of thing. But just anorexia itself means you don't want to eat, but or you don't feel like eating. But then the cachexia thing is just when your nutrients are being stolen by the tumors. So anyway, so the wasted appearance, and I have it on the notes page, concentration camp look. And if you ever look if you could just Google Holocaust and look at images and stuff like that, you might not want to look at it, but that's what some cancer patients can look like. And then their tumors secrete substances that alter the taste and smell and produce early satiety. Have you heard that term? Satiety means you're satisfactorily full, that you've had enough. Really, that's really what you're saying. Like satiety is like, okay, I've eaten 2 bites. That's enough. I don't feel like I need any more. So early satiety means you're not going to eat enough. And so you're getting full too quickly. And there's widespread catabolism of tissue and muscle proteins. And that's, anabolic steroids, we talk about that. Anabolism is building up. Catabolism is breaking down. So widespread catabolism. And so, we know you just studied metabolism, didn't you? So anabolism is building up. Catabolism is breaking down. So it has increased destruction plus decreased intake can lead to that cachexia. So, and let's see here. We already talked about the diverting the nutrition. You can have pain and infection that contributes to the anorexia. You just don't feel like eating because you feel so terrible. and the catabolism, the muscle proteins and all that. Okay, so we mentioned the bleeding out, and if you see, I think we've mentioned this maybe before, but exsanguination. I don't remember if we mentioned that in 111 or not, but sang is means blood. I think that sang or song, however you want to say that, with it's French and Spanish, and I don't know, some other of those, you call them Romance languages that were derived from Latin and all. So if you do see a word like sang, this is exsanguination. The blood is going out. Bleeding out can occur. So that's exsanguination. That's the way doctors sometimes put on somebody's death certificate, that was exsanguination. So that's what that means. So if you see that particular part of the word sang, that's probably going to mean blood. And instead of you sang a song, no, that's different, of course. Okay, and then we've got that dysgeusia. That's a really wacko word, but I just put that in there because I think it's kind of cool. But it is an interesting word. It's a distortion of taste sensation from the cancer or the treatments. Like I was mentioning, that there's a lot of chemicals sometimes that are secreted by tumors and it makes you might want to be eating, you might be hungry, but you can't eat it because it tastes so terrible. And so that's what dysgeusia is. All right. So our clinical manifestations, those paraneoplastic syndromes, and that results from chemicals that are secreted by the tumor. That's just what I was mentioning. Those chemicals can be messing with your taste and your hunger and your all of that kind of stuff. But also it can cause lots of other things, and we'll talk about some more of that in a second. We can have acute or chronic pain, and the cancer can be the cause. Or they may have pain related to the treatments, because sometimes when you have surgery, you're going to have some pain when you have surgery, and then you can have acute or chronic pain because of the tumor growth, putting pressure on nerves and such. And you can have physical stress and psychological stress. So all of those things play in. And so the perineoplastic is an indirect effect of the cancer, and it can cause ectopic sites. Have you heard of an ectopic pregnancy? Y'all are going to deal with that in 114, but ectopic means it's not where it's supposed to be, or not what it's supposed to be doing. So it's a ectopic hormone production. Increase in hormone production. So it's like parathyroid hormone. It can cause hypercalcemia. And in ADH, or antidiuretic hormone, that can cause hyponatremia. So you're decreasing in your sodium, and increased blood pressure and edema and fluid retention. What I had read too, though, you do have a hyponatremia, like when you look at it on the lab roster, it'll say that you have a lower sodium, but really it's not originally that the sodium is low. It's that the fluid is high. The water, you've got too much water in your system, and so it dilutes the sodium, and but you do literally have hyponatremia when you look on the lab report, but it's really it's a accumulation of fluid that dilutes the sodium. And then the ACTH, that adrenocorticotropic hormone, and it increases cortisone production in the adrenal glands. And you can think about all the side effects from corticosteroid drugs. I'll probably talked a little bit about, I maybe talked about that with the metabolism part, and you can have that Cushingoid symptoms that with the increase in the cortisone. You get the fat face, and you have a buffalo hump on your back because it sort of builds up like that, and you can have a big belly. And so you can also, the perineoplastic can either either the tumor produces insulin or the tumor produces a chemical that will tell the pancreas to make more insulin. So this is really weird and strange and all, but that's how it happens. So it can also cause hematologic abnormalities in your and in your kidneys, the nephritic, cutaneous, and neurologic syndromes. And pain is one of the most serious concerns or dreads of clients and their families. And they even, a lot of people are more afraid of pain than death. They'd rather die than be in pain. And I don't blame people for that. And acute pain has the well-defined pattern of onset, and chronic pain lasts more than about 6 months. That 6 months, if you read in another source, it may say 3 months, 4 months. There are some variations in that definition of chronic pain, but anyway, I've got it on the source that I had. It was 6 months, but I have read some other things too. But anyway, don't worry about that. But the autonomic nervous system adapts to the chronic stress, and it makes the manifestations less defined than the acute pain. You just sort of get used to it. And it can cause personality changes and altered function and lifestyle disruptions. It can make you depressed. And clients that have pre-existing pain and those with a history of drug abuse, and they can have altered perceptions of pain and may not respond typically to pain medication. And in the dying client, the pain can be associated with hopelessness and death. And it can then intensify the perception of the pain and contribute to that suffering for the client and the significant others. So cancer pain can be caused by direct tumor involvement or the side effects or toxicities of the treatments for the cancer. So physical stress can be caused by depleting the body's energy resources, and like it tries to fight the invading cancer cells. And there's a tremendous energy is required for that process to fight the invading cells. And it does result in exhaustion and fatigue and weight loss and anemia and dehydration and possibly lower levels of their electrolytes. So that can be a bad thing, certainly. And then our psychological stress, grief and guilt and anger and powerlessness and fear and isolation and body image and sexual dysfunction. And those are a lot of concerns. And psychological support from the nurse during the diagnosis is active listening and supportive to the patient, but do avoid giving advice or false reassurance, because people, it's so easy to say, oh, it's going to be all right. Oh, it's going to be fine. Oh, you're going to be okay. Don't say that, because you really, you don't know. You really don't know. You're just going to say we're going to do all we can for you, something like that. That's, yes, we can say that, but we're not going to say, yes, you're going to be fine. So no, that's just, it's so easy to want to say it though, because you want to make that person feel better in that way. But in the end, it's really not a good thing. It's like, okay, that person lied to me. That's even worse. Then you got all these other psychological distresses, and then you know that somebody lied to you because you're progressing with the cancer and such. So anyway, we don't want to be judgmental, and we want to provide appropriate information and make it available to the family or the significant others. Okay, and the exemplar of anticipatory grieving, I bet y'all have looked at your psych area, and I think that that's addressed during the psych one. That's one that Ms. McCoy did. But the anticipatory grieving within my unit listing on our concept-based curriculum too is an exemplar. So I'm going to do just sort of briefly, but it's an adjustment of self-concept in the face of potential loss, like death or loss of body parts or body function or loss of the significant person or an animal or possessions, or a loss of a social role. So that's not necessarily for cancer, but that's the definition of anticipatory. It's a brief one anyway, but you can assess the patient and have a trusting nurse-patient relationship. You assess the patient's coping skills, like if you've had other tragedies in your life or problems in your life, how did you deal with those? And try to see if you can use those. If they worked for you, then let's use those. If not, let's try to find something else to try to help you. And then you're going to have your open-ended questions. You're going to assess your causes and contributing factors to the grief, and you're going to use your support system. And you're going to teach the stages of grief and allow time to make the nonverbal support to encourage the expression of feelings. You want you want to know how they feel, and that's really the key is therapeutic communication is the key to helping people express their feelings. And so you want to be honest, but you want to encourage hope also. And you're not going to say, well, you're going to die. But yeah, okay, well, 99% of people die from this. Like, no, don't say that. But anyway, you want to try to encourage the hope. And in terminal cases, and then activities as able, even work if possible, for the increased continuity of your life. And you can also help plan the funeral and burial to give the client and the family members a sense of control, or at least to have, you may not be able to have time to do that yourself, but like in hospice and things, that's a little bit different. They can help in a little bit different way than an acute care hospital. But that at least if they need some help, you can find some resources or check with the case manager to help them as well. So anyway, we want the family members and the patients to have at least some sense of control. And again, what I mentioned before is the patient is the center of the plan of care. So we really need that to happen. Okay. We're going to talk about some diagnostic tests. So we do assist in decision making in the treatment, and it might include in our diagnosis a biopsy to take out a bit of tissue and examine it under the microscope, bone marrow aspiration, and a CT scan, MRI scan, PET scan. Radiography is just a regular X-ray, and ultrasound uses sound waves. And then the body fluid studies. And so I wanted to go a little bit further with our CT scan, the computerized tomography. And it's a general assessment of locations of the mass and the involvement of the vessels or body organs. And you got to check for the patient to see if the patient is allergic to iodine that's used in contrast. I read somewhere that the iodine in CT contrast doesn't cause the allergic reactions like a regular iodine allergy, but this new Davis book still says it, and it's a very recent one, and I would not take a chance on that iodine thing. Don't believe that until it's absolutely evidence based. So yeah, I would not. If you read that, just say okay, and unless we know definitely that it's not going to hurt the person. But evidently people have been allergic to that. And maybe you've had really bad reactions. So our MRI is magnetic resonance imaging, and it displays 3D images with or without contrast. It doesn't have any iodine in it though, so that's one good option. And it's easier to see the details of small structures. So though that's there's differences out. Some people need one way and some need the other. If you need to have a contrast, the MRI may be better if you're allergic to iodine. So anyway, there's lots of different ways to make the decisions. But anyway, the PET scan it's called positron emission tomography, and you administer radioactive glucose tracer. It's a it has glucose with radioactive chemicals in it that the images show hot spots of metabolic activity. So that's the whole thing. It's where in the body are the hungry areas. That's really what the tumor cells want to just be metabolizing all the time. And so it's not always true that that's a tumor when you see that high metabolic activity, but it's suspicious anyway. And it's the hot spots of the metabolic activity, and the cells absorb the rapidly or then the rapidly developing cells, and and so it can absorb the tracer and can rapidly, get the rapidly dividing tissues and help to detect the cancer. And I have learned so much just in the last few years because of my parents. And my mom had a PET scan, and her PET scan showed up high metabolic activity and a whole lot of lymph nodes. And so the radiography doctor, the radiologist said that it looks like it's suspicious for lymphoma. And so there was a high metabolic activity there, but when my mom had biopsies of her lymph nodes and her bone marrow, and she had some pleural effusions, and she had all of those areas had B cells, B lymphocytes. They were mature B lymphocytes, but they were not malignant. They were normal looking cells, but a whole bunch of them were there. And she died before we could find out for sure whether she had lymphoma, because it never did show up in those several areas that it was malignant. But there may have been, there are some lymph nodes way deep inside that they're hard to get to. You'd have to be very invasive to get to that. And my mom wasn't in any shape for that, so we didn't learn. But anyway, yeah, her PET scan did say it probably was lymphoma. Okay, so our direct visualization is like endoscopy. When you have scopy at the end, that means you've got cameras and you're taking pictures in there, and you can even take biopsies and or take off like colon. The colon polyps. So endoscopy, colonoscopy, cystoscopy. So endoscopy is when you're doing it in the esophagus and stomach area. And then the colonoscopy, of course, is from the other end. And the cystoscopy is into the bladder. So it may detect polyps and tumors and remove the biopsy through the scope, require the prep or someone invasive. So it may require sedation or anesthesia. And it with colonoscopies, I've had several of them, and I just had one in July. I think I told you all that before, but they gave me the oh gosh, now I can't think of the name of what Michael Jackson died of. That makes you feel kind of weird, but yeah, these people, these anesthetists and anesthesiologists know what they're doing though, and that guy was not an anesthesiologist of Michael Jackson, but I can't think of the name of that. Oh shoot, I'll have to think of it. But anyway, you go to sleep just immediately, and then you wake up just almost immediately too, and you don't have all this amnesia like you used to have with like Versed and Ativan. So that was a good thing. Okay, so microscopic studies. Oh, wait a minute, I missed something. It's the most radical method of the direct visualization is the exploratory surgery with biopsy. So, and that can be like the laparoscopy, and that's a scopy where that they may put it into your belly button, or they can put some punctures in the abdomen, to be able to look around, to put the cameras in and look around, and collect a biopsy possibly. And then microscopic studies of the cells and tissues, the samples from a needle or excisional biopsy, because if you can just take a needle and pull up just a little sort of thread of tissue with a needle biopsy, but if you're doing an excisional biopsy, you're actually just taking out the nodule or whatever it is. So let's say you can have exfoliated cells to be examined, like a cervical smear or bronchial washings. They can go down with a bronchoscopy and put saline in, sort of wash it out, and then suck it back out, suction it back out, and then test to see if there are any cancer cells in the bronchial tubes, and in collections of secretions like a sputum specimen, and aspiration of fluid from body cavities like the pleural effusion. Like my mom she had like 2 liters taken off, 1 liter in one lung and one the other. And then cerebrospinal fluid, that's what the CSF is. So you can look at cerebrospinal fluid by doing a lumbar puncture, or the blood lots of blood analysis, lots and lots of blood tests are available. And the only the microscopic histologic examination, like histology, has to do with tissue. So histologic examination, and it's of the tissue, reveals the type of the cell and its structural difference from the parent tissue. So the microscopic is really the big deal. So blood tests. There are tumor markers from serum or other body fluids, like you measure in proteins and enzymes and hormones and antigens, and they either shed from those cancer cell surfaces, or they're produced during the host response to the tumor. And they may be normal in small amounts, but might be elevated with certain cancers. And they're most useful in monitoring the response to therapy, detecting the residual disease. And it's also, you can look at your details on cytology and tumor markers and oncologic imaging and direct visualization and lab tests used for cancer diagnosis. If in a lab book or something, if you want to look further into how those things work. My dad had a blood test for alpha fetoprotein because with hepatocellular cancer, he had had a PET scan actually too. I don't know if it might have been a CT scan. I can't remember which he had now, but it did show some lesions in his liver, and so the oncologist took an alpha fetoprotein, because that's another one of those paraneoplastic kind of things. We have a little bit of alpha fetoprotein in our bodies, but you're not supposed to have much of it. And so if you have real serious and progressive hepatocellular cancer, you're going to have a big elevation in alpha fetoprotein. But he did not. His were when we were talking about that differentiation part, his tumors were much better differentiated. They were more like the tissue of origin in his liver. And so it didn't even show it. So it wasn't even far along enough for it to do the alpha fetoprotein, or just to see that the alpha fetoprotein was elevated. It was not. So we ended up having to get one of the tumors biopsy. They were trying not to be invasive because he was 86 years old, but they did go to the radiology guy, the interventional radiologist, and he got a sample, and they were afraid they wouldn't be able to get it, but they did, and it definitely was hepatocellular. So then he did some further radiology treatments and things at Baptist Hospital after that. So anyway, this is one of those, like, you teach and teach and teach this, and then it happens to your parents, and or somebody else in your family. It's like, oh, good grief. Oh. So anyway, I've learned a lot. So here we go with naming cancers, and this came from the National Institutes of Health. They're the National Cancer Institute is part of the National Institutes of Health. And let me see, I'm trying to find my phone. What did I do with it? Oh, I'll get it in a minute. But anyway, adeno means gland and chondro means cartilage. You can look through all of those kinds of things, but you may know a lot of these already. But erythro is going to be a red blood cell, erythrocytes. The hemangio has to do with blood vessels. Hepato is liver, lipo is fat, lympho is lymphocyte, melano pigment, myelo is bone marrow, and myo is muscle, and osteo is bone. There's lots of other, excuse me, I don't know why I'm so hoarse. Anyway, so that's how you can look at it as a, you can say an adenoma, or if it's a cancerous lesion, it can be an adenocarcinoma, and it could be chondroma or chondrosarcoma, erythro. Well, I don't know how you would look at that one. That one doesn't really fit, but hemangioma or hemangiosarcoma, something like that. But like the osteo means bone, so the cancer arising in bone, osteosarcoma, adenocarcinoma, breast adenocarcinoma. Carcinomas do originate from the embryonal endoderm and ectoderm, the epithelial tissue. So that's really like a skin type of thing on the sort of outer areas. And sarcomas originate from the embryonic mesoderm, the connective tissues. So, and then the liquid tumors are lymphomas and leukemias, because those are very related to the blood cells. And so it originates from the hematopoietic system. So you don't need to memorize this, but I want you to just see what that means, because and so adenoma is not going to be a cancer, but that could be something that you might have to deal with, if somebody has a surgery for something like that. So that might help you. I'm not going to test you on that or anything, but I think it's just something that you can have as a resource. Okay, I'm going to run and get my phone and check right quick. Okay, so we're going to do another about 15 minutes. I just didn't want to yak forever here and make y'all too bored here. So classifications of cancer is staging. This is a very simple way. It is complicated in like breast cancers and lung cancers and lots of different cancers, but this is very basic. But this is what you need to know is like the higher the number here, the worse the prognosis is. So clinical staging, we can have 0 is cancer in situ, where it has is sort of got a covering around it, and it's not invasive. There are abnormal cells in there, but it's not invasive yet. So they call that 0, cancer in situ. So then the tumor number 1 is tumor limited to the tissue of origin. Limited, and 2 is limited to local spread, and 3 is extensive local and regional spread, and 4 is metastasis. Anytime that you see a stage 4, it will be metastatic, where it has spread to another system in the body. So the staging does classify the solid tumors and refers to the size of the tumor and the extent of the disease. So the higher the stage, the more extensive the disease. So I want you to remember that. High numbers are bad. That's just it. So grading is another thing. It determines the level of functional maturity, the differentiation, how malignant or aggressive the tumor is, and how close it is to the tissue of origin. So the higher the grade, the worse the prognosis and the more difficult to treat. So, so actually, like what my dad had was, he did have a well differentiated, all of his tumors were well differentiated, and they were like the hepatic tissue of origin. And he didn't die from the hepatic cancer. He had it treated with some radiation beads and stuff, and they really had disappeared. But he had hepatitis C. He had blood transfusions back in the late 60s and early 70s, and he would have he had ulcers in his stomach, and they didn't know about the oh god, I can't think of the name of it. That stuff I always get started and then it flies out of my head. But anyway, it he had the ulceration, and he had the oh god, what do you call it? I can't think of that name. But anyway, he had the infection. It was a organism that was causing it, and once you treat it, then you can get rid of those ulcers. But they didn't know about that, or they didn't know about hepatitis C at that particular point. So the hepatitis C was just, it's kind of insidious. You don't even know you've got it. And Dad had a little bit of elevation in liver function tests, but not much. And it was just sort of stable. And also they didn't really think anything of it about the hepatitis C. And then he ended up having, when he had that, I think it was a CT scan, his doctor was looking at it for, because he thought he had some pancreatitis and where his pain was. And then they found out that those hepatic cancers were in there, those tumors were in there. And so that's when they really saw he had cirrhosis of the liver. And see, it's like it sort of goes from there. You go hepatitis C, and it's in there for a long time, and then eventually, as you get older, it can cause damage to your liver. And so he had the liver damage. So that liver damage from the cirrhosis is what caused the hepatocellular. So the hepatocellular things the lesions were cured. I mean, they were gone, or at least they had the total response there. But then the cirrhosis started kicking up, and he started getting ascites, having a lot of fluid in his abdomen, and then that portal hypertension and the esophageal varices, and the cirrhosis is what killed him instead of the hepatocellular. So he did have a well differentiated tumor, or set of tumors anyway. There were like 5 of them. They were small, but anyway, so it was not as malignant as some tumors could have been. And then so the higher the grade, the worse the prognosis and the more difficult to treat. So that if you do have like a real high alpha fetoprotein, or whatever the blood test is that you're looking at, then that can be a real signal that there's a problem, and the prognosis will not be good. So our doubling time is how long it takes a tumor to double in size. And then so that makes sense. That's probably easy to remember. But mitotic index, the percent of actively dividing cells. So a mitosis is the end of the division process, right? So the percentage of the actively dividing cells, that means that if it's a high percentage of cells that are dividing in the tumors, the larger the number, or the percentage of the number, the more aggressively the tumor is dividing, and the greater the growth rate of the tumor. It's small or oat cell carcinoma of the lung, and the lymphomas and leukemias divide very rapidly. So let's see. I'm gonna have to, that's driving me crazy about that stomach thing. When we have a break, I'm gonna look it up, whatever that other name was. I was trying to remember. Okay, so this picture is kind of a mess here. And you've seen some of these other ones that we had last week, but here's some benign tumor cells that grow only locally, and they can't spread by invasion or metastasis. So they're very much like normal cells, but they do have some local spread. It's not invasion though, and it's not metastasis. So it isn't that. And then the malignant cells they do invade the surrounding tissue and enter blood vessels and metastasize to different sites. So it's just, this is sort of the process here. I'm gonna see if I can get my little laser thing. Gosh, sometimes it doesn't want to participate or whatever. Okay. Well, I've got to, yeah, I don't know. Can y'all see my arrow? I don't know if you can see, because
Yes.
it's not, what's that? You can?
Yes.
Oh, good. So I don't have to have the little red thing then, huh? I don't know why. I guess something's going wrong with my control thing on my computer. It just does. I'm supposed to do Control L, and it should show a little pointer thing. But anyway, if you can see the arrow, that's okay. And so here you're seeing these blood vessels they're abnormally created there. They're real fragile. They do feed the tumor, but you can have a lot of bleeding if they end up having a lot of pressure in that area, and that you could have an internal bleed from a tumor that has those blood vessels that are very weak inside, and then you're taking it to a whole other place. So here we got our mutation inactivates the suppressor gene. So we want to suppress growth if we don't need those cells. So the mutation did inactivate that. Cells do proliferate. Mutations inactivate the DNA repair genes. So here, yeah, this was benign to start with, but then here it's inactivated the suppressor gene, the DNA repair gene. And then proto-oncogenes mutate to oncogenes. So the more mutations that go on, the more genetic instability and metastatic disease. And tumor cells can be at any stage. They can be, some of them can be well differentiated, and others can be so undifferentiated that you may not even be able to tell where the tumor came from. So this is the figure for metastasis through the bloodstream, and the cells secrete enzymes and a motility factor that wants it to go forward and move, and it disrupts that basement membrane in the blood vessels. And this way the cancer cells gain access to the circulation. And once they're in the blood, there's only about 1 cell in 1,000 escapes immune detection. But that can be enough. The undetected cells do move out of the blood, and they secrete enzymes and cut through the vessel wall into new tissue. And that tissue is selected for establishing a new tumor. It might be downstream from the original tumor, or a chemical attraction might cause the malignant cells to target a specific site. And that is called chemotaxis. I don't know if y'all have heard that before, but for some reason it's the target area is calling for those cells to come to that area, and it may be because the tumor has already secreted a messenger to try to make sure that it's sort of like a magnet or a homing device or something, and that's just, it is such a cruel process. But anyway, once it's in the new site, the malignant cells multiply and establish that a metastatic tumor. So well, I think I mentioned the other day that those chemicals, we have all these signaling chemicals are what you have, what you're trying to target when we're doing targeted therapy. We've been trying to do targeted therapy for, gosh, probably 50 years, and now we're trying to target the cells themselves, and that's not the answer. You're having to target what's signaling the cells. There could be signals inside the cell and outside the cell. So that's what we're working on now for the target. It's not the cell itself, it's the signaling chemicals. So all right, and here's another one. I know this one's sort of the same thing, but here's a blood vessel, and here's normal cuboidal epithelium, and then up here these are abnormal up there. So I guess I can't. I've got that. It's not going. Oh well. Anyway. It's not going to let me see the very top of it. Anyway, the malignant transformation, and some of the normal cuboidal cells undergo the malignant transformation and have divided enough times to form a tumor area within that cuboidal epithelium. And then tumor vascularization. You see those blood vessels there that they're pulling from the regular, or from their normal blood vessels. They're pulling it up into the area to feed their young, I guess you'd say. So cancer cells secrete a tumor angiogenesis factor, and it stimulates the blood vessels to bud and form new channels that grow into the tumor. And one of the targeted therapies is Avastin, and it's been around for a good while. It's a IV medication, and so it helps it blocks this tumor angiogenesis factor. So that's the way that particular one works, and it's especially in like colon cancer tumors, and it can be in some other kinds of glandular tumors, but it works best in pretty much in GI tumors. Anyway, this blood vessel penetration, that cancers have broken off from the main tumor, and enzymes on the surface of the tumor cells make the holes in the blood vessels and allow the cancer cells to enter the blood vessels and travel around the body. So you see that they're loose now. They are on the loose. And then we have the arrest and invasion. So cancer cells clump in the blood vessel walls and invade the new tissue area. So this is some other tissue that was normal and now it's not anymore. And if the new tissue areas have the right conditions to support the growth of those cancer cells, the new tumors, the metastatic tumors, will form at this site. So that's just a scary thing. And again, that chemotaxis, the chemicals in the cells that coax the tumor cells into particular tissues. So they kind of know if they're going to be able to live there. It's almost like they have their own cognition or something like that. And that is creepy, don't you think? Ugh. So I'll check my time here. Okay. Yeah, let's do break, because I've got like 7:58 on my phone. And so why don't we come back at about, not 7:58, 10:58. My phone's, I'm looking at it on the wrong thing. Anyway, it's 10:58, and so we need to go on with our we'll just do it at 10:10. I mean 11:10. I'm so messed up with this. 11:10. So y'all can come on back when at about 11:10, and I'm gonna go ahead and stop sharing for a little bit here. Yeah.
You want a record?
Yeah, I sure will. I'll just go ahead and do that now. Here we go. All right, thank you. So it is H. pylori, and it is one that a germ that does fight not fight it, but it can live and thrive in all of that hydrochloric acid. I mean, that's really, you would think that almost anything could be killed, and that's most things do get killed in the stomach. But you know, when we have a stomach virus, there are viruses that live there and go through your not urinary tract, your GI tract and all that. So yeah, that we're not 100% protected by that hydrochloric acid. So anyway, H. pylori, and then I started to look for anesthetics, and as soon as I started typing, I said propofol. There it is. It's propofol. That's the anesthetic that killed Michael Jackson, but it really is great for colonoscopies, because you don't have to feel like you're not with it anymore. Because they used to do Demerol and meperidine. We're supposed to say generic, I guess, but meperidine, that's Demerol, and like Versed, and I can't think of what that one is, but it is benzodiazepine anyway. But it makes you really, really have amnesia, and you never get it back. I had it that first time. I was like, let's see, it was in like 2000. So yeah, and this is 2020. So that's 20. Yeah. So I was like almost 44 then, and I was having some pain in my like left upper quadrant, sort of strange, and I think it ended up being a diverticulum that was causing that problem, and we had a family history and all this kind of stuff. But yeah, when my husband would come and help me wake up and everything after the my first colonoscopy, and the second one too, you just have total amnesia. You talk to the doctor comes in and talks to you, and then you don't remember it at all. And I did not remember seeing the doctor at all those 2 times. And so it's so much better to have propofol, because they get you to sleep right quick, and they get you awake right quick, and you monitor your O2 sats, and that's about it. It's wonderful. Oh, she already put that down. Oh, I see, Brandy. I didn't even look at that chat, but yeah, I wrote that down when we were doing our break thing. Yeah, and so, and I guess we'll go hit back and get to our classifications for our TNM classification. All right, let us go to share screen. All right, can y'all see?
Yes, we see.
Okay, thank you. I just want to be sure, because sometimes it doesn't pop up right, or I don't make it pop up right, whatever it is. But so classification of the cancers, the TNM, the T is for tumor size, and the N is nodes. You've got that, so that's for lymph nodes. And then the M is for the metastasis. So TNM classification, staging. And again, this is a very simplification of it, but as long as you know the principles of it, that any of those high numbers are high, it's bad. Okay, the higher the number, the worse it is. So on the notes page, it will tell you the T is relative tumor size, depth of invasion, and surface spread. And it will vary according to what body system that you're working on. And the N is presence and extent of lymph node involvement, meaning that the lymph nodes have some cancer cells in them. And then the M is the presence of or absence of distant metastasis. So if you have an M0, that means there's not any metastasis. And so let's see, there is a T in your book. I don't know that if they tell you that one. I didn't put it in the PowerPoint, but if you have like a TX.
Excuse me, Ms. Beaver. I'm sorry, I don't know if it's me, but are you recording?
Yes.
Oh, okay. I couldn't see it on my screen, so.
Oh, okay. Well, you want me to look and just see? Let me share a second, because I did did click it. Huh. I clicked on the thing. It's not.
Abir, all the PowerPoints are recorded and they're posted on Blackboard.
I know.
And it's all of the same information.
I know.
I clicked on that and it didn't go. And I'm glad you said that though. Thank you, Abir, because I do want to have a good recording of it. So anyway, most of that other stuff. Okay, I just fixed it though, because I did go back to the other screen, and so I did. It is showing now for everybody, right?
Yes.
Okay, I guess I just maybe I didn't hit the right thing, so because I don't know why it didn't go. Anyway, it's going now, so thank y'all. All right, so let's go on to this again. So we got our tumor size spread to lymph nodes and metastasis. So I don't think that I have that on your notes page, but if it has TX or NX or MX, like below your T and M and M, that means that it can't be assessed yet. There may be some other kind of tests that need to be done that it can't be assessed at this particular point, because there's going to be a point where you can usually find out what the classification is or what the staging is, but there may be some maybe complicated diagnosed or diagnostic tests that are just not, things are not showing up. Well, just like my mom, you couldn't tell because she had all those B lymphocytes that were perfectly normal, but there were a whole lot of them. So there's something going on with that, because B lymphocytes deal with they are memory cells, and they are and other B cells are the ones that are antibodies that make the antibodies. So anyways, the antibodies and memory cells are there. That's like, what was the problem there? We just never did know. So my mom would have had, the X's on hers. But anyway, so, yes. Did I not? Is it not on? Oh, so it didn't. Oh. Yeah, let me see what I did then. Let's see. Share. Let me just start over here from current slide. Oops. Wait a minute, I'm going to. There we go. Can you see that? Okay. Oh, I'm sorry. I guess I just did. I guess I missed a click. There's so many clicks you have to figure out. Thank you. All right. So our classifications then, we're going to see that basically a less aggressive tumor will be a lower stage with that TNM method, and highly differentiated, which is low grade, and the long doubling time and a low mitotic index. So in any of these numbers, that means that it's low, and it's not as likely to progress. So we have an aggressive cancer that would have high numbers on the TNM with any metastasis beyond the regional nodes, considered a stage 4. So if there's any metastasis at all, there may be 1 site or 2 sites or 3 sites or 5 sites or whatever, that it doesn't really matter if the cow's out of the barn already. Just even if it's just the metastasis 1, that's still not a good thing. It's a grim diagnosis kind of thing, or grim grading of it. So, okay. And let's see, the undifferentiated, that unlike the tissues of origin, and low or non-existent functional maturity, that's high grade. And if it has rapid doubling time and a high mitotic index, if you have like a 75% high mitotic index versus a 5% mitotic index, like which one of those would be the worst? Anybody know about the? It'd be the 75, wouldn't it? Because you've got 75% of those cancer cells dividing at the same time, and if it's only 5%, it's going to be like a slower growth or slower progression if it does progress. So anyway, the lower the number, for mitotic index, doubling time, and grade and functional maturity, all of those things, any of those are those numbers, if they're higher, you want to realize that that's not gonna be a good thing for your patient, and the prognosis is going to be possibly more grim. It really depends on what body system that they're working on, and some of the like stage 4 with some of the head and neck cancers that come from the HPV type of head and neck cancers. They can't, like Michael Douglas had a stage 4, and he's acting again and all that. So that's that when you can have a long remission or a cure for that. And then like with Hodgkin's disease and testicular cancer can be cured also. They can have let's see, I guess anyway, what's his name? I can't think of it right this second. Oh, I always get so tongue tied here, but
Ms. Beaver, I have a question.
Yeah.
Mm-hmm. Could you elaborate just a little more? I'm just a little confused with the differences between the undifferentiated and the well-differentiated.
Oh, and that's one reason why I like teaching in relation to those embryonic cells, because those embryonic cells, when we were looking at that as right after fertilization in those 8 days during that particular period, and there's all of this, there's no differentiation at all during those 8 days. They're just dividing, and then all of a sudden these chemicals within are sending signals as to whether you're going to grow a spinal cord or a brain or a heart or bones or whatever. And so then that is differentiated. It knows exactly what it's supposed to do. And it knows exactly how it's supposed to look, or what shape is it, or what size is it, how dense is it, all of those kinds of things are differentiations. So well differentiated is when those cells know what to do, and they should be in the right size and shape and all that. So that would be well differentiated. But when they go back to what those, like how the embryonic cells were acting, that's very abnormal. That's the only time in a person's life is those 8 days that are undifferentiated. That's normal then, just those 8 days. But if it happens any other time, that's abnormality, definitely. So I hope that kind of helps, because unless there's something wrong with those chemicals that are signaling them to the embryo, then everything's going to be differentiated, and every cell knows what it's supposed to do. And then cancer, it's just the total opposite. It starts to go backwards and into what might have been like what the embryonic cells would do. It's a regression type of thing. So the well differentiated, like my dad's cancer was more like the cell of origin than a lot of people. A lot of people got theirs diagnosed much later than my dad did, because my dad's doctor was looking for something else and then found it sort of early in the hepatocellular section. So he did do well with that part because it was well differentiated and it was easily destroyed. But in if they're not well differentiated, it can be much more difficult. So and it is more of a likelihood of having metastasis. Does that make sense, or do you have a specific question about that?
It makes perfect sense. Thank you.
Oh, okay.
So does the differentiation just mean like it's different than the regular cells that are supposed to be there, or different from the other cancer cells in that like localized area?
Well, it doesn't. Differentiation really does mean that it's unique. It's unique for its own functional system area. Like when we looked at some of those cells, like well, it was just a drawing of a cell, but there was a skin cell and a nerve cell, and a red blood cell, I think is what we were seeing. But those cells were well differentiated because they had their right morphology, the way they're put together, their structure and everything. That system is well differentiated, and each of the types of cells have their own instructions on what they're supposed to be doing if everything's normal. And so it can go to undifferentiated though if the cancer attacks. So there can be signals that are wrong. They and especially like environmental factors, or there can be genetic factors, of course, too. And so some embryos are not going to be normal, but there's always genetic issues there, that the genes have to be messed up to be undifferentiated. So it can be an environmental kind of things like exposure to radium or lots of chemicals and things like that, pollution, smoking, and sometimes like things together, like drinking and smoking and doing illicit drugs and all these kinds of things that can mess with your immune system. So the normal cells will regress down to sometimes even almost to where it would be just like a embryonic cell that just doesn't know what in the world to do. So does that help too, or
Yes, ma'am. Thank you.
Oh, okay. Yeah, it's an interesting. I really understand it better because of the embryonic thing, and I'm so glad that we had a book. After I started working, in teaching, I hadn't really looked at it in that perspective, but it really helps me to understand it, and I hope I'm not confusing y'all with it. But it really it is our only normal time of when right after fertilization. That's only when it will act like that, and cancers act like that, and it's not supposed to be that way. It goes back to immaturity. So, okay. Well, let's see. And that sentence at the end of that notes page, that may be what's confusing you, but you may say that there's that it's highly differentiated. If it's highly differentiated, that means that's good. It's highly differentiated because it knows exactly what to do and it's doing what it's supposed to. But the grading is the high grade means that it's very undifferentiated, and that's where it kind of was a confusion issue, I think. So the high grade is when it's undifferentiated. All righty. So let's go to our corrupt surrounding environment. So, all right. So our growth factors equal proliferation. We got invasive mess here. We got a matrix there with a bad cell, fibroblasts and adipocytes. That's fat tissues, and we got some misses here. It's just a chaos thing. So chaos and anarchy and all the molecular changes that occur within a cancer cell environment changes dramatically, and the cancer cell loses receptors that would normally respond to their neighboring cells that call for the growth to stop. And so the tumors amplify their own supply of the growth signals, and they flood their neighbors with other signals, and they're called cytokines, and enzymes that are called proteases. And we know what ASE is. It's an enzyme, right? Anytime you hear like proteases or lipase or all of those kinds of things, it's going to, or amylase, ASE is always going to be, well, I guess it's always going to be with enzymes most of the time. So then this action destroys both the basement membrane and the surrounding matrix. And it lies between the tumor and its path to metastasis, and a blood vessel or duct of the lymphatic system can carry it away. And so some of these things are from the NIH site. The National Institutes of Health, or the National Cancer Institute is under National Institute of Health. So up to 50 to 60% of all cancers have metastasized by the time the primary tumor has been identified. So here's our pathogenesis of the metastasis. So here's primary tumor growth. So it's in one area of tissue. Okay, we got our angiogenesis. That's our creation of blood vessels, and it's creating its own blood supply instead of using the normal blood supply, and shunting away the nutrients from the normal tissues. And then our capillaries and venules and lymphatics take it all over the place. And then we have adherence. This is inside of the blood vessel. And then there's penetration into the organ from the blood vessel when it decides that that's where it's supposed to go. Like that chemotaxis is like your lungs are waving at you to say, oh, hey, come here. We want you to come here for some reason. Then that's because of an abnormal signal. And then we've got the circulation. It goes in the transport part, and then the response to the microenvironment, the tumor cell proliferation and angiogenesis. So it settles down, it may just be in one spot, but it could go to multiple spots, or it can just start with one spot, and then that one spot continues to metastasize within the organ. So it can be coming from the primary tumor multiple times, and it could be that the ones that are already settled in are moving along inside that same systemic area, and even maybe going to another area such as the brain. I had read an article, gosh, it's been years ago, that there seems to be, like when you have lung metastasis, that it's more likely that you will have brain metastasis. Not everybody would have it, but it seems like if you have like breast cancer, and then the breast cancer goes to the lymph nodes, and then the lymph nodes take it to the lung, and then the lung sends it to the brain, and that there's some kind of weird issue there with because we have we have the blood-brain barrier, and you're not supposed to have bad cells go up into your brain, but there are exceptions, and it can certainly happen. There's some way that it shunts it and can escape the blood-brain barrier and go to the brain. So and if it's a lung cancer, just the lung cancer has started, and that can go up to the brain, directly. So that's a kind of a scary kind of pathway there. Okay, and then here, these are our main sites of the bloodborne metastasis. I keep thinking that I've already said this because I'd recorded this stuff. I'm like, wait a minute, I said that before. But anyway, no, I didn't say it to y'all yet. So here's places of main sites of metastasis. So we've got the brain and oh, cerebrospinal fluid is so tiny on my screen, lung and liver and adrenal glands, and then we've got the bones. So here, this is the vertebrae. So, and you can see this on your, I guess you can see this on your notes page. So that's the vertebrae, and this is sections of the brain, and that's the way that CT scans look. They take like slices of it. So that's what they're looking at and they're targeting here. And here's the liver. It's really, my dad had like 5 liver nodules, but these are multiple. And here's adrenal glands. Adrenal glands aren't that big, but they can easily have metastasis also, and mess with your hormones. I mean, that really, like your epinephrine and your cortisol. And then here, oh my goodness. And some of y'all may have seen, like in elementary school or junior high or something like that you've seen some smoker lungs. And I don't know if this is a smoker lung. It doesn't look black. They usually look black. They have it in a jar or whatever from the American Lung Association, and it's gosh, what's going on with my? There we go. Anyway, it's all shriveled up, and that person obviously died. I mean, they took it out of their body, and they it just, you couldn't have any perfusion because there's no elasticity in any of that. It looks like it's just dried up, totally dried up. So that it's a terrible, injurious kind of thing. All right, so our physical assessment is dependent on where that alteration occurs, and you continue to assess, of course. So you're going to assess all the time. You're going to look for the nutrition and hydration status and assess the clients for the early warning signs of cancer. And I've got that on your notes page, the change in bowel or bladder habits. And it's the 7 warning signs. I don't think it's real. I don't have a good association thing with this to just memorize it. But if you look at all of those 7 things, I think you'll be in good shape. But the change in bowel or bladder habits, that could be, you could have a change in any place in your body. But anyway, change in bowel or bladder habits, a sore that does not heal. I think that's a little weird to say that, but unusual bleeding or discharge, thickening lump in breast or elsewhere, indigestion or difficulty swallowing, obvious change in wart or mole, nagging, cough, or hoarseness. So all of those adjectives, I really would rather have had nouns on there and got some different word, but I guess caution is a good thing, but I just can't, I can't really associate it that well. I just have to kind of have a general idea of it. But anyway, do read through all of those and several times so that it will be kind of in your head, and you don't have to say it exactly. You can paraphrase it if somebody was asking you to list that, but I do want you to be familiar with it. So let's see, the client teaching, we're going to address health practices and developmental assessment of children as part of assessment. We're going to assess for stress and coping abilities. We already mentioned that, really. And psychosocial support when we talked about the anticipatory grieving, as well as physiological signs and symptoms. So you recommend a balanced diet is tolerated, and I want you to make sure that you circle this or underline it or highlight it. High carb, high protein diet. Because it does take a lot of energy for your body to fight the cancer. That's just part of it. And you have to do that to maintain the weight for clients with cancer. Now, if somebody has like ovarian cancer or like liver cancer, things like that have a lot of fluid retention in like you might have ascites or you might have pleural effusions and have a lot of fluid. That way your weight would be higher, but you're not well nourished. You have to take that into consideration if there is ascites and such for that weight. So there's not one nutritional plan that can meet the needs of all cancer patients. So you've got to individualize. There's not one size fits all, but you do need to have enough carbs and enough protein to repair your body and maintain it too. And then, and so antioxidant foods and vitamins and supplements in larger serving doses than the RDA can theoretically interfere with the oxidative processes that lead to the cell kill when you use chemotherapy agents and radiation therapy for cancer. And what they're saying is that RDA is that recommended dietary allowance, and it can interfere with that oxidative process because a lot of vitamins and supplements are anti-inflammatory and antioxidants. And so the antioxidants, that's a good thing if you're trying to just maintain your health and all. But when if you're on radiation therapy and or chemotherapy, that it actually, those methods actually kill those cells by oxidation. And so if you're going to take antioxidants, and if antioxidants work, then your antioxidants are going to interfere with that process, or they could interfere with that process of the radiation or the chemotherapy, causing the oxidative death of those cells. So if the patient does want to take the supplements and everything after they have finished their courses of treatment, then they can check with their oncologist and say, well, when can I start taking some of these other things that make me feel better and things like that. And so we do want to be careful about that and make sure that we ask our patients whether they are taking, what all are they taking over the counter. So I've been taking a whole bunch of stuff now, but golly, the anti-inflammatories and such. But anyway, we do need to be careful about that and make sure we know what our patients are taking, because it's not, some people still think that unless it's a prescription from the drugstore or from your doctor, then that could be a big deal. So off. Oh, okay. Now, so our complementary health practices, the eating more fruits and vegetables, a minimal of 5 servings daily, and protect skin with sunscreen with all ages and all skin types and all climates. There's 1 or more severe burns in childhood or sunburns. It increases a risk for skin cancer. So the skin does remember all sun exposure throughout the lifespan. It really does. And that's you do accumulate it, just like you would accumulate when you have like a dosimeter. If you work in radiography, they have a little badge thing that you can tell how much, they can tell how much radiation that you've been exposed to, and you'll have a certain limit as to how much you would have in your lifetime. And so that this is sort of like that with our sun. The sun has radiation also. So we do, our skin does remember all of our sun exposure throughout our lifespan. So we discourage smoking and avoid secondhand smoke. We test our homes for radon and be aware of the potentially hazardous chemical exposures in the workplace or at home, and encourage the clients to learn more about any family history of cancer and suggested surveillance and or ways to decrease risks, and teach adolescents and adults about recommended cancer screening for early detection, like breast self-exam and the pap smear and testicular self-exams and skin exams too, because you could sometimes people find the melanomas, and the melanomas are the most dangerous, but even the basal cell and squamous cell skin cancers, if you notice that something's different on your skin, you probably need to go to you could go to your primary care, but they may tell you to go further and go to the dermatologist. So the V vaccination is very important for young people, and I don't know how that's gonna. It may be for everybody eventually, because HPV is very widespread. So anyway, we're going to have a regular developmental assessment of children during treatments for cancer. It'll be a standardized tool. There's one example that's called the Denver Developmental Screening Test. And so you observe for developmental milestones and signs of regression. I don't know why I have, if less than 6. Okay, less than 6 years old, that's what that means. And then refer to the neuropsychologist if there's problems. And in childhood cancers, the child and the family support needs to include the siblings also, because the siblings can be real jealous about things like that. And I do have, if I have time on Wednesday, I'll read you something. If not, maybe I can get a copy of it and post it for you. But anyway, talk with the teachers before returning to school to explain the condition and the treatment, and help with plans to prepare other children for the return to school. All right, so collaborative care of cancer, and this is just in general right now, but curative therapy, it can involve surgery just by itself or extended periods of systemic therapy that goes all through your body. And the control is a treatment plan that has an initial course and maintenance therapy. And for palliation, the goal is relief or control of symptoms and maintenance of quality of life. So quality of life is really, really important. Palliation or palliative care and the hospice, that's the emphasis, is quality of life. There are some other differences, but the quality of life is the biggie. And so here on our notes page, the goal of cancer therapy is to increase survival time and the quality of life. Sometimes people really don't want to live any longer because they're miserable and nothing is working, and they just want to go ahead and have comfort care. And so the goal is to increase survival time and with the quality of life. So we don't want to just force people to just keep taking treatments just to keep yourself alive if you really don't want to be. Okay, here this is just kind of a mess in a way, but it might if you just look sort of through it, the initial treatment phase, you're going for cure or going for control or going for palliation. So going for cure, you'll do follow-up phase and no return of cancer in the usual lifespan. So any of these could be part of the treatment. And then with our control, you're going to do follow-up and see if you need more treatment. It's not cured, it's just being controlled. It's not spreading anymore, but it's not getting any better either. So you're going to continue with either some of these particular types of treatment. And then you get to that retreatment phase, supportive phase, and usual or reduced lifespan. And we'll just have to see how that works out. And then sometimes when you're still in treatment and you still have cancer, you may die of something else. You might die from a stroke or die from the car accident or something like that. So not everybody will die from the cancer if they are controlling it. Okay, so palliation or no response to the initial treatment. So again, we got the surgery, chemotherapy, radiation, biologic, and targeted. And then that advanced disease supportive phase, reduced lifespan, and hospice care. So that's just this is sort of pathways, and that's not something I'm going to test you exactly on but those are just the ways that it would go as far as treatment decisions and such. So the team approach to collaborative care, that's the best thing to do for a client with cancer. And our 3 treatment approaches, there's really more than 3. You got to look at it in a certain way of categorization, but surgery is usually the most common or the first thing, not necessarily, but a lot of that. And then radiation, and then chemotherapy. So I put pharmacotherapy now to include the biologic and the targeted and the hormonal therapies, as well as cytotoxic medication. So cytotoxic means it's poisoning the cells, right? So then this other thing is photodynamic therapy. I don't know why in the world anybody wants to really emphasize that so much, but this was another one of those reports from Kaplan and NCLEX that, oh, your students didn't know anything about photodynamic therapy. Like that's one of the most rare kind of treatments that we have, and I think it would be more important to know about chemotherapy and radiation therapy and surgery. But anyway. So I'll tell you anyway. So our chemical reaction is a chemical reaction triggered by types of laser light that destroys some cancers, and it shrinks some tumors to allow decreased extensive surgery and relieves obstruction, like in the GI tract and the respiratory tract, like in the bronchial areas, in the esophageal area, like the throat or esophagus, and non-melanoma skin cancers can respond to that, and eye tumors, and bladder tumors also. And they have a dye that goes into, that is injected into your system. And the dye leaves the normal cells faster than the cancer cells, and so the cancer cells can have increased sensitivity to light for several weeks. And my dad had a type of diagnostic test that had something like that where the cancer cells would maintain the dye, or would retain the dye, and they called it washout for the normal cells. The normal cells would have it in their cells, but then the normal cells would send it out quicker than it would from the cancer cells. And so that's a way that you can do diagnostic testing too. I really didn't realize that they could do it this way, but this is what they're doing for photodynamic. And so there's the laser light that just can destroy the cancers when it has that particular type of dye or substance in it that will kill it, and it will sort of retain most of the normal cells. So anyway, that's photodynamic. All right. Surgical therapy, and that's to cure or control disease processes of cancer, and it's a localized form of treatment. And the cancer arises at a slow rate of proliferation or a replication, or tumors pressing on the nerves or airways or other vital tissues. You just need to get it out. And if the intent is to be curative, the margin of the normal tissues have to surround those excised tissues. So when you're taking like a node out, or if you're taking a tumor out, then you want to make sure and look at the area that is surrounding that tumor, to make sure that, because you may have to dig in a little further after you take the actual tumor out, and dig in a little further until you find that there's a clean margin and there's no cancer cells in the surrounding area. So the surgery is to remove diseased tissue, and it's the oldest form of cancer treatment, and it is sometimes curative. They found some things like that in mummies in Egypt, and I don't know how in the world they learned how to do all this stuff, because they did treat cancers, and I don't know all the details, but they did treat cancers. And it was you could still even tell when they would x-ray the mummies and see that there were lesions, and that maybe that's what that patient died from. But anyway, prophylactic, the pre-malignant condition or strong familial predisposition to cancer, colon polyps, and moles from irritated areas. So yeah, I have my colon polyp off, and my son and husband have had moles. Well, my two sons, both of them have moles from irritated areas. And diagnostic is biopsies for the histologic diagnosis. Again, histologic is looking into the tissue and staging. and then the curative, the all visible and microscopic tumor is removed or destroyed. And robotic surgery is available in a lot of cases to get the desired therapeutic effect, but they can maintain more function as they're like decreased impotence and incontinence with prostate surgery. Some people have it worse than others or have more nerve damage and things like that. But anyway, the robotic surgery, and I keep thinking that I've told you this too, but I'll say it. I went to a conference, gosh, probably about 7 or 8 years ago in Atlanta at what is this? Northside Hospital, and they had most of the people that were speakers were like doctors that were oncology people, and so this fellow was more with like the prostate surgeries, and he had a lot of problem with his neck. His neck was really not being very flexible, and he ended up really having some damage to his cervical vertebrae, and he ended up having to have surgery. And so he wasn't able to like bend his head down to be able to operate like that anymore. And so he researched as he was recovering from his surgery. And I mean, he researched this robotic surgery, and so he made a proposal for a grant or something or other to buy a robotic system to do especially like prostatic surgeries, and it worked out really well for that hospital. They did either get the grant or the hospital allowed them to buy it. I'm not sure how that worked, but anyway, he was able to learn how to use it. He said it was like learning how to play a video game, because you're remotely doing the actions. But some of that, we've had statistics on the impotence and the incontinence with prostate surgery patients, with versus like robotic surgery versus the regular surgery. And for a while there, it was looking like it was less likely to cause impotence and incontinence. But then there's all these little tests that or experiments and everything that are they're trying to do evidence-based practice, but I think it's still sort of the jury's out. But it may be that it's fine either way, depending on especially the skill of the surgeon, whether they're doing robotic or the regular surgery. But anyway, it was very interesting. He had all these slides about it and everything, and he was very excited about it to be able to stay in his profession. So you're going to remove only as much as necessary and use adjuvant therapy like radiation or chemotherapy, and preventive measures that are used to reduce the surgical seeding of the cancer cells, that like cysts removed intact, like we mentioned before, the seeding. We don't want to have instruments to carry cancerous cells into other areas of the body. You're going to have to keep switching your scalpels or your other equipment. So, and let's see, the usual sites of the regional spread can be removed, like the lymph nodes. And for control, that's not going to be cure, but control. Debulking, you're going to make the lesions smaller, or on cytoreductive. You won't have as many cells left behind. And it is not curative, but it can give other therapies a greater chance of success because there's not so many cells to treat, because it can be overwhelming to try to just do chemotherapy if you still got so many cells, really bulky tumors, large tumors. So anyway, palliative, we're going to try to improve the quality of life, of course, and it might not be the length of life, but quality. And the relief of pain and obstruction or dysphagia. We have the two dysphasias, one dysphagia, and if you look at that, it's GI. So that means the swallowing kind of dysphagia, and the other kind of dysphagia has an S, like speech. So that's how I remember it. If you have an S in there, it's speech or cognition and stuff like that, and the GI one is the swallowing. So adjuvant therapy is radiation or chemotherapy after surgery to stack the odds in the client's favor with the goal to eradicate all the cancer cells when you're intending to cure the patient. And then with second look surgery, that happens with like ovarian or some other abdominal surgeries. You determine the effectiveness of the treatment used in the ovarian, where the tumors are often seen along that omentum in the peritoneal cavity without obvious tumors large enough to show up with the radiological tests. And it's used to determine the effectiveness of the intraperitoneal therapy given via the abdominal catheter. It's sort of like a gosh, let's say, can't think of, I can't believe my brain's just doing this anyway. But anyway, the catheter that you put in for, for the urine, put it directly into the bladder through the abdomen. And it's like, it's sort of like, also like your they called it a Tinkoff catheter that would go into the abdomen for like, peritoneal dialysis. But anyway, you're going to try to determine the effectiveness of that therapy. What you can do is have a tube in to the abdomen and to access that abdominal cavity. It's really more so like the peritoneal dialysis catheter, and you put medication inside the abdominal cavity and let it dwell, is what they call it, like for peritoneal dialysis. It dwells there for a certain length of time, and then you pull it back out like through a catheter. It would be sort of like a urinary catheter, and then sort of rinse it out also. And so let's see. Okay, yeah, I think I got that one. But yeah, there's you really could do it. I don't know if they would even do it sort of like a laparoscopic. I'm not sure how they're doing all of those. I need to talk to my gynecologist and see what she says, what's new about that. Anyway, reconstructive or rehabilitative surgery, that increasing function and enhancing appearance, like breast reconstruction after a mastectomy, and the penile implants after a nerve damage from the prostate surgery. So it doesn't have to be penile implants. There's other kinds of things that they can do about that. But those are some things that they had for a good while, and there's lots of different ways to get your reproductive system going. Okay, so our radiation therapy. This is going to be sort of complicated here. I'll start it up, and then we'll finish that up in a little bit. Okay, so radiation therapy, it emits and distributes energy through space or material medium. So it ionizes and excites whatever it's going through, and it breaks the bonds in the DNA, and that's the main thing. So I've got mine started and highlighted on that one. Breaking the bonds of the DNA is really the way that it works, and it causes the loss of the proliferative capacity. So the normal tissues are usually able to recover at least better than cancer cells do. About 50% of cancer patients receive radiation therapy, and I do want you to remember this on this notes page. I've got mine highlighted here. It's localized treatment. Localized. When you do radiation therapy, it is aimed at just a specific area, and it is not systemic usually. I mean, I'll talk to you about that in 211. So let's just look at this as a localized treatment and aimed directly at the tumor and confined to that area. So the modern equipment does minimize scatter to other regions and organs. And we have a new cancer center in Salisbury at Novant, and it's a really, really advanced machine for the external radiation therapy, and it doesn't scatter as much. There's going to be some damage to tissues right next to, like if it's a esophageal, if you're trying to radiate your bronchial tubes, then the esophagus could suffer from that because it's so close to it, and you can't miss it. It may cause some damage to the esophagus, but it's much more accurate than it ever has been. They're getting better and better at these new machines. So it may follow surgery. The radiation may follow surgery or to kill any cancer cells left behind after taking the tumor out. And so that's called adjunctive. And there's also stereotactic radiosurgery, and it's a one-time treatment to like a small, well-defined target in the brain or other parts of the body. There's a procedure called CyberKnife. Well, it's actually it is a piece of equipment too. CyberKnife is most commonly used for that. So the radiation is delivered to the tumor during surgery while the CyberKnife is giving the radiation too. So, and it decreases injury to the normal tissue. So it's just very precise also. And then it can be palliative to relieve symptoms of the inoperable cancers without expectation of cure, to shrink the size of the tumor, pressing on the organs or nerves, and to relieve the pain and dyspnea or dysphagia. Okay, and so we're going to just look at this. This is like 2006, but I think it's in your one of your books. I think it's in the Elsevier book. Yeah, it is. It's an Elsevier thing. I think it's still in that particular. I think it's the 9th edition. And so here it just shows you that alpha rays are blocked. That this kind of radiation, alpha radiation, is blocked by paper, and beta rays are blocked at the body, and it doesn't go inside. And then the gamma rays go all the way through the body, and lead does block it. There's some other ways to do radiation too. This is a simplistic thing, but you can tell that the gamma rays are going to be the effective ones in most cases. So our ionizing radiation exposes the cancer cells to tremendous energy, and resulting in the cell destruction or interference with cell division. And it naturally occurs in radium and cobalt, and it's called gamma radiation. So radium and cobalt, there's more. There's cesium and yttrium. My dad had yttrium beads in his liver. Okay, so this is a really, really, really busy page, and then I'll stop and we'll have a break. But this is a linear accelerator. This is a new picture. I just put this here because I wanted to kind of cite it as where I got it from. The Covenant Health System has purchased 2 true beam linear accelerators designed to focus radiation beams and track motion to follow the target if it moves. I mean, that's the type of thing. It's going to. This was one from Tennessee, I think. So, but that's a more modern one. I had a different picture from a textbook that it looked like an ancient kind of thing. So I wanted to make sure you saw the newest kind. So what we need to look at is a few terms here. Is exposure and the amount of radiation delivered to the tissue. I think I actually moved this to your previous page to make it spread out a little better. So anyway, that is probably on a different page than I have. So exposure is probably on your one that we were looking at the beta, alpha, beta, gamma. So exposure is the amount of radiation delivered to the tissue, and you have to wear a dosimeter or radiation exposure badge if you're working in X-ray or radiation therapy. And the dose is the amount of radiation that's absorbed by the tissue, and is determined by the intensity of the exposure and duration of exposure and the closeness of the radiation source to the cells. So some cells do die immediately, with radiation, and others die from impaired cell division. Then they can die eventually, and others can repair the radiation damage and recover. That's the scary part. Some of them can fight it and start replicating again. So normal cells do have a greater capacity to recover than the cancer cells do, and not all cancer cells are identical. So different cells respond differently to cancer treatment. So fractionation, that's giving radiation in divided doses, so fractionated, to achieve total prescribed RADs. And radiation absorbed dose is what that stands for, RAD, radiation absorbed dose. And they used to use RADs routinely, but now what they're doing is it's called a gray. It's a capital G, little y. And 100 rads equals 1 gray. I just want, you don't have to memorize that or anything. I just wanted to let you know that they're probably going to, if you've got a patient taking radiation therapy and you're reading like a progress note or something like that, then the grays, if you see the GY, that's 100 rads. One GY is 100 rads. So anyway, grays is probably what you would see, but I like that radiation absorbed dose. At least we can tell what that means, and it allows a greater cancer cell destruction over time, and it decreases the damage to the normal tissues. And the dose depends on the type of tissue and extent of the disease. And like normal liver cells are more likely to die than cancer cells in the liver. So this external radiation therapy is not used much in this case. But my dad's was, he had his radiation beads, those yttrium beads that went up through his femoral vein up into those liver blood vessels, because it was interventional radiology. They could see what they were doing, and so that was yttrium has a real short half-life, and so they didn't take it out of the system because it just will die, because you've got the half-life and half-life, and so it's not going to be a danger to other people until about just a few days afterwards. So anyway, that's a whole new treatment deal. Anyway, the computerized treatment plan has to be instigated. They've got to get that taken care of, and it takes a while to go through the working with the machine and knowing exactly where they're supposed to aim this. And this is called teletherapy. So this is not something that's going to be inside the patient. It's going to be a beam from the machine to the patient, but it's not sending the radiation source to the patient. So the client needs to be in exactly the same position every single treatment, and they should not wash off the markings on the skin. That's one of the things when they do the treatment plan. They may put some tattoos on that are just little dots for a tattoo to make sure that they get the machine aimed exactly the way that it's supposed to be. And sometimes they just do like a Sharpie pen and draw on it too. And you don't want the patient to, the patient can take a shower or something, but don't scrub, over those areas. And so to make sure that the patient does not wash that off thinking that it's dirt. And the type in these photos is the teletherapy for the external beam radiation. So I want you to know that that's external. It's the source is external, and then the radiation beam is it goes in and affects it breaks the it messes with the bonds in the DNA. So okay, so. Where am I? Okay. The source is outside of the patient, and the patient is not radioactive. The machine is radioactive, but the patient is not radioactive. The external beam therapy is usually given 5 days a week for 15 to 30 minutes a day over 2 to 7 weeks. There's lots and lots of regimens though. But I did read in that in that Davis book that they still do the 5 a day and 2 days off to rest a little bit in between treatments. So if you wash the skin marked at the radiation site, you're only going to use plain water and no soap. Don't apply any deodorant or lotions or medications or perfume or talcum powder to the site during that treatment period, unless the doctor specifically orders like a water-soluble, maybe aloe-based lotion to treat skin effects. And you do need to make sure that that your radiation therapist knows, or your radiology doctor knows that what you're putting on that. You're going to ask what they recommend, because you don't want to ruin anything, because that could make you have a bad burn if you have certain ingredients in certain oils and things in lotions and all. So aloe has been a good thing. My mom had aloe when she had radiation with her breast cancer when she was 60 years old. So that's what they recommended for her, is an aloe based. But you want to make sure that your particular doctor is prescribing or telling you what to do, but even if it's over the counter. Okay, so take care not to wash off the treatment marks. Yeah, I've already said that before, but I think we need to say that again and mark that. Do not wash off the treatment marks. Do not rub, scratch, or scrub treated skin areas. And if necessary, use only an electric razor to shave the treatment area. Or you could just clip, if you can do something that will clip close to the surface there on the skin, and apply neither heat nor cold. You don't want to have heating pads or ice packs to the treatment site, because that could damage the tissue, or the tissue could already be damaged. And you're going to inspect the skin for damage or serious changes and report them to the radiologist or physician, and wear loose, soft clothing over the treated area. Protect the skin from sun exposure during treatment and for at least 1 year after radiation therapy is discontinued, and cover the skin with protective clothing during treatment. And once radiation is discontinued, use a sun blocking agent with SPF at least 30. Of course, the rest of us need to be doing that too if we're in the real hot part of the day in the sunshine. And then external radiation poses no risk to other people for radiation exposure, even with intimate physical contact, because that patient is not radioactive. They have just had a radiation treatment. The radiation went inside them, and then it may take a while for it to complete the damage to the abnormal cells. So then be sure to get plenty of rest and eat a balanced diet. All right, let me see where we are at. Okay, let's come back at gosh, that's going to be about 12:30, isn't it? So then we'll do another half an hour, and then we'll wind up. Okay. Let's want that phone number for Elsevier, because I don't know if they make changes all the time, and if there's some kind of problem that you can't understand. I think I'm going to go ahead and put this down again. That Elsevier, because that I don't know why it's doing that, because they don't always tell us that they've made a change, and so I don't know what they want us to do on that. But it should be a 2 year I guess you'd call it a subscription, not a prescription, a subscription. All right, I guess I better get back to our share screen, and whoops, I'm going to do a record first. It's showing recording to y'all. I see it. Do y'all see it? Okay. So, all right. Yeah, I think we got that going. All right. So, Come on, there we go. So let's do from current slide. All right, and this is an immobilizer device to keep the person to be in the right spot so that they can aim the beams at the right place. So the second type, we just talked about teletherapy, because tele means it comes from the outside, someplace besides you. It comes from another place. And so this one is brachytherapy. I don't even know what brachy stands for exactly, but what it is internal radiation. And the source is in direct contact with the tumor tissues for the prescribed time period. So the source might be solid, which is sealed. It's like an example of seeds implanted in hollow needles in the prostate or breast tissue. And if they're unsealed sources, it can be like an oral liquid or capsules that can be swallowed and distributed to a target organ. And the iodine 131, like for thyroid cancer, I've learned about that with thyroid. And it's the same, and for hyperthyroidism too. But it is in higher doses for cancer. And the radioactive substances can also be injected into the bloodstream or a body cavity, or introduced into the tumor through a catheter, which that's what my dad had. And it might transmit rays outside the body or be excreted in the body fluid. So that's where the brachytherapy is the patient, yes, the patient is radioactive while they have that in their system. And like with my dad's, it was that yttrium was a really, really quickly, it quickly dies. I mean, its lifespan is really, really short. So you don't have to take it out. And then it's like that. Then they put little seeds into prostate cancers in some cases as well, when they just leave the beads in there, but that it's already decayed. They really call it decay for radiation. So anyway, it may transmit rays outside the body or be excreted in the body fluid. So you're going to have to be careful and follow directions if you're going to be at home. If you've taken that iodine 131, like drinking it, or if you have the IV and then they send you home, you're going to be in a special. You're going to be in a separate bathroom, and you're going to make sure not to be with small children or pregnant women, or pregnant or somebody that could become pregnant and maybe doesn't know it yet. So anyway, the client does emit radiation while the source is within the body, and it is a potential hazard to others. So if the source is ingested, which is unsealed, it doesn't have the needles around it or anything, it's just a liquid. There's special disposal of the urine and the feces, and it's in you need a private bathroom and stay away from the pregnant women or young children. So it's for the capsule, the oral liquid, or the IV is if it requires the special disposal. Okay, so I do want you to remember this on that notes page: time, distance, and shielding. Put a big highlight on that, or a big star or something, but you do need to remember this test and forever, because this is a real important about radiation. It's essential to practice when you're working with brachytherapy clients, and the nursing care should be planned so that the nurse spends as little time in the room as possible and stays as far away from the patient with the radiation source, and as much time as possible behind a lid shield while you're performing care. And the patient has to have a private room, and visits are limited to 10 to 30 minutes, and visitors must sit at least 6 feet from the client. And the client and family teaching is, while a temporary implant's in place, you stay in bed and rest quietly to avoid dislodging the implant, especially if it's in a cervical implant. I took care of a patient when it was my first year after getting my license, and we were at the very end of the hall. It was not a special unit. We were at the very end of the hall, though. So it was, people that were sure they were not pregnant and all that were able to take care of the patient. And so you had to be very efficient. You had to plan ahead. And if there was anything that the patient needed, you could, call if they did their call bell, and you could ask what they needed and bring things all into the room and get things done as quickly as possible. And there was a big lead shield in there to stand behind when you were talking to the patient. And when you're taking care of the patient, you're going to need to do some vital signs, and you be close to the patient, but not for long. You don't want to be there. We need as much distancing as possible. So anyway, for outpatient treatments, avoid close contact with others until the treatment has been discontinued. And if the radiologist indicates the need for such measures, dispose of excretory materials. That's the urine and the feces in special containers or in a toilet that's not been used by others, and carry out daily activities as you're able. Get extra rest if you're feeling tired, and eat a balanced diet. Frequent small meals often are better tolerated, and contact the nurse or physician for any concerns or questions after discharge. And then the safety principles for radiation for caregivers working with clients receiving internal radiation, the brachytherapy. And there also is a chart in IGGI about these safety principles. I would highly recommend to look at that. I think I wrote down chart 24-1, and I know some of y'all may have edition 8, and some of you might have edition 9, but in some of them it's the same. It may be the same number of chart, but see if you can find the radiation one if I don't have that down right. So maintain the greatest possible distance from the source of radiation and spend a minimum amount of time close to the radiation source. Shield yourself from the radiation with lead gloves and aprons when possible. And if pregnant or could be pregnant, avoid contact with radiation sources. If you work routinely near radiation, wear a monitoring device to measure whole body exposure with the dosimeter. Avoid the direct exposure with radioisotope containers and don't touch the container. And keep clients with implanted radioisotopes in a private room with a private bath and as far away from other hospitalized persons as possible. And dispose of the body fluids of clients with unsealed implanted radioisotopes with special care and in specially marked containers. And handle the bed linen and clothing with care according to the agency protocol. Use long-handled forceps to place any dislodged implants into a lead container, especially for like if it's in a breast, if those needles, they're very long needles. They're like 6 or 8 or 10 inches long anyway, and they're in like the very middle of the needles, and so sometimes especially when it's cervical, because you can't really see down there is exactly how that's working. You do need to check and make sure that it hasn't become dislodged, and that's one of the things the nurse has to check on. Let's see. Okay. Handle the bed linen. We got the long-handled forceps. If the implant does come out, then you use the long-handled forceps. That's one of the procedures that you have when you even start out with taking care of the patient. They have all of the containers, the lead containers. And you don't just grab it with your hands. Of course, don't do that. And do the long-handled forceps because you want it as much distance away from that source as possible. And then consult with the radiation therapy department with any questions or problems in caring for the clients with the radioactive implants. So those are interesting. All right, this is something that you don't have to know how to do with the math right now, but you're going to need to do it in 211, and it's really kind of fun. You probably don't think so, but anyway, this is the inverse square law, and the intensity of radiation exposure decreases with the distance from the source. So if you got it 1 meter, it's going to be a certain number of rads exposure. If it's 2 meters, you're going to put 1/2 squared, which is 1/4. So you only have 1/4 of that exposure. And if you're at 3 meters, you'll put 1/3 squared. So 1/9, you'll only have 1/9 of the exposure. And then with the 4 meters, it'll be 1/4 squared, which is 16. 1/16, you'll have 1/16 of what the person at 1 meter would get. So that the time, distance, and shielding, the distance, that's extremely important. So the intensity of radiation exposure decreases with the distance from the source. At 4 feet away, 1/16. It's important if any source of radiation leakage, accident with radioactive cargo during transport, you could even, be helping somebody in a wreck. And if there's radioactive materials on the truck, you want to, and it may have been, maybe something was broken open and exposed, you would want to pull, even if it was just 1 or 2 feet away from it. It is exponential to be the further away you can do, even if it's just a few feet, but as much as far away as you can get the person away, and yourself as well. So anyway, if the exposure is 64 rads at 1 foot, how many rads exposure at 4 feet? So you'll do 64 times 1/4 squared, which is 1/16. So you only get 4 rads versus 64 rads. Isn't that amazing? So just realize that, and there could be some sort of a radioactive accident in our nuclear medicine area in our hospitals. There could be some kind of a big spill or something that would be a problem, and you want to make sure that that you want to get people as far away from that source as possible. So that's the big point. Don't worry about the math right now, but we'll be doing that in 211 in the summer. Okay, so I'm doing some side effects, and some of these side effects, well, I think all of them really are, they can be noticed as far as with radiation and chemotherapy. So with anorexia, not wanting to eat, monitor carefully to avoid weight loss and weight. Well, this is just a suggestion as far as the weight twice weekly, that you want to keep up with their weight anyway. And then small, frequent, high protein, high calorie meals, as patients do need energy. And then they need protein to build up their if they do have some problems with the normal tissues with radiation or with the chemotherapy, then you want to be able to have protein in order to repair the normal cells. And then you can have some supplements that do have the vitamins and minerals and lipids and proteins, all that. So the abnormal taste and odor perception can lead to anorexia and weight loss in cancer patients. It can be from cancer itself or from the treatments. And high protein foods, especially red meat, are often reported as having an unpleasant taste and odor for cancer patients. And I've often heard from my patients when I was doing chemotherapy and all, they would say about red meat, the more I chew, the bigger it gets. And protein foods like chicken and fish and eggs and cheese are often better tolerated and more pleasant smelling and tasting. Some people don't like the smell of fish, but if you have a real mild kind of fish, it might be like eat fish sticks or something like that, like little children like. But anyway, the patients they might have aversions to high fat foods like chocolate and certain vegetables and caffeinated drinks. And food aversions are individual, though. Not everybody looks at the same thing or eats the same thing. So there's a careful assessment needed before suggesting a nutritional plan for each client. And the results are still controversial, but the research is underway to discover whether zinc supplements can help prevent or recover taste alterations caused by radiation therapy. And zinc is actually a component of the taste bud membrane. That's pretty cool. It hasn't been like a officially evidence-based practices. I think that they've just had really small studies for it, but there are some people that do benefit from having zinc when they're on chemotherapy or radiation therapy to help with those taste buds, and it can make the patient feel more hungry or more willing to eat, and so I think that's a good thing. Yeah, I had a patient that was taking some really powerful emetogenic. That means that it's very likely that you're going to throw up. It's going to make you sick. And so she ordered her supper, and it was like fried chicken livers and potatoes or something like that, and fried potatoes. And I told her I didn't think that was a good thing. You might want to just ask for some chicken noodle soup. And she said, no, I'll be fine. Well, she just barfed her guts out after her treatment. And that's, that I wanted to give her a suggestion to at least start mildly, and then if you work your way up maybe and see what you can tolerate, but don't do that the first time. So anyway, in the National Cancer Institute website, the cancer.gov, eating hints for cancer patients. It used to be a book that you could just order and they would send it to you, but now it's on like PDF. But you can look on that website. I have it on my website list on the Blackboard. So rinse your mouth with water before eating, so you're not going to have a real dry mouth, because a lot of times the radiation or chemotherapy can make you have a dry mouth. Try citrus fruits like oranges and tangerines and lemons and grapefruit, unless the mouth sores are present, because if it's real acidic, your mouth's gonna be very sore. Eat small meals and healthy snacks several times a day, like grazing. Eat cheese and maybe some sort of protein-rich crackers or breads or something like that. Eat small meals and healthy snacks several times a day. Yeah, eat meals when hungry rather than at set meal times. And use plastic utensils if foods taste metallic. Some cancers cause metallic taste in the mouth, and then others it's the treatment itself does cause problems with the metallic taste. And try your favorite foods, and eat with family and friends. Have other people to prepare the meal, so you don't have to smell it all the way through. Try new foods when they feel the best, and then substitute poultry and fish and eggs and cheese for red meat. Find non-meat, high-protein recipes in a vegetarian or Chinese cookbook. We've got some of there's some grocery stores have the plant-based protein that mimics meat. I actually I went to one of these. Oh gosh, I can't remember what it was called. But anyway, it was one that was a fast food place that you get a bowl of something or other, and it was like the impossible protein or whatever, and it looked like ground beef, but it was plant based, and it tasted like ground beef, but not so fatty. It wasn't so greasy. So use sugar-free lemon drops or gum or mints if there's metallic or bitter taste in the mouth, and spices to sauces and food, or in the foods, whatever the patient likes as far as spices. And eat meat with something sweet, like with cranberry sauce and jelly or applesauce. And okay, I'm going to look at a few of these pictures for some of these other side effects. Dry desquamation, because that's our squamous cells on the shoulder there, and it's gotten sort of burned there, like a sunburn, except for it's so dry, and it's more like a flaky type thing. So it's you have a skin protection chart in your IGGY book. It's a chart 24 during radiation therapy, if you want to look at that in your book. And then the wet desquamation, so that one's oozy, and so that it might continue after the radiation course is completed, and the effects might be delayed. So what the doctor will do, if they do the 5 days on and 2 days off, 5 days on and 2 days off, and getting close to the end of like a 6-week treatment, they'll give them an extra break and then start back over again. But it can continue, because all of the cells don't die at one time. Some of them die immediately, and some of them will die later. And so even after they finish their radiation treatment for a few weeks, it could even get worse. And so that's certainly, they need to go back to the doctor and see what they might need to do, maybe use something different to help it to heal. So here are skin reactions. The dry skin should be lubricated with non-irritating lotion or solution that contains no metal or alcohol or perfume or additives. And the wet reaction, it's weepy and raw. You have to keep it clean and protect it from further damage, and all interventions have to be approved by that radiation oncologist. Definitely remember that. You've got to know that the radiation oncologist is approving what you're using. And aloe-based gels are water soluble, and you don't want to use it is no petroleum-based products in the radiation therapy field, because it can enhance the burning of the skin. It's like it's frying you in oil or something. That sounds gross, but you don't want to have aluminum-based deodorant in the area of the radiation. And you want to go for preventing infection and facilitating wound healing and protecting irritated skin from extremes in temperature, certainly not ice packs or heating pads, and avoid constricting garments and harsh chemicals and deodorants. So let me see where we're at here. Okay, so we've got, I know you all have this. This is a nursing student, right? So you encourage the patient to identify times of the day when they feel better, and that can allow, you can have allot your activity tolerance to certain things that you prioritize. So you might, there's some things that you think you just have to do. Is it really necessary, or what do you very much want to do? What's your favorite thing, or make a list, and what is the very most important thing that you want to accomplish today, kind of thing. So decide priorities on how to ration the energy among the most important activities, and rest before and between activities, and get assistance with activity, and maintain nutritional status and an exercise regimen if possible. And then short power naps have been found to be more effective for most cancer patients in renewing their energy and fighting the fatigue, as opposed to hours of napping at one time. It makes you just more groggy and drowsy. And if you're not being active at all, then that, it's like if you lose it, wait a minute. If you don't use it, you lose it, right? So you may also be a delayed reaction or increased after the radiation therapy is done, or the chemotherapy. And so it can be, you can be tired for months and months and months. My mom had radiation therapy to her underarm area. She had just a few cells in one lymph node, and she took tamoxifen, and I'll tell you about that later. But then she did have a lumpectomy. Hers was right lower quadrant, and she had radiation to that right lower quadrant of the breast and in the underarm area. So let's see, let me do one more, because this is oral here. Oral and oropharynx and esophageal reactions. So you're going to teach the patient to examine the oral cavity, and dental work should be performed before initiation of radiation therapy if it's possible. And it's like that for chemotherapy also, because it can affect your mouth. It can especially if you've got radiation in the oropharynx or something like that, or if you're taking chemotherapy that does cause effects on normal cells, especially in the mouth. They call it mucositis or stomatitis. So it's better to go on and get some dental work done if you can. But if it is urgent, you're going to have to go on and take your radiation or chemotherapy if it's very urgent. But you can use saliva substitutes to keep your mouth moist. There's one called Salivart. There's lots of other things that you can use, but it makes it sort of slimy, like snot, I guess, if you would say, but that's what mucous membranes are for, to have a smooth area and not have your mouth dry, and you need to have oral care. So xerostomia is a word for dry mouth. Xerostomia. So stomy means or stoma means an opening, and it can lead to taste alterations, and especially metallic tastes or aftertastes. And it can make the mouth more susceptible to injury and cause difficulty swallowing. So that's not a good thing. And it's often caused by the radiation damage to the salivary glands in the head and neck cancers, because some salivary glands may not be able to produce anymore. It may be so damaged that, and maybe the cancer itself is in a salivary gland. I had my uncle's wife had cancer of the salivary gland, and she eventually died from it. She had some responses, but then she eventually progressed and died from that. But anyway, we definitely don't want to use any. I've got H2O2. That's peroxide. Do not use peroxide. So you all know about that. But as far as like the trach care and everything, you know that it takes away. It sort of dissolves protein. It destroys the proteins. So we don't want that to happen, because we want to have some new tissues being able, or granulation tissues to be able to come back into the mouth and throat and all that. Okay, and since I've got oral and everything, I want to finish this one. So oral and oropharynx and esophageal reactions, we want to have some pain relief. You can use a medication called it's sucralfate. It's on your notes pad with esophagitis and stomatitis. For your mouth and esophagus, and Carafate was for ulcers. It was for stomach ulcers, and it was a great big pink pill. And so before we had the liquid kind. We have liquid kind now, but they used to crush it up and put it in with some sort of a syrup or something that would taste good, that wouldn't irritate. And it would that if you would rinse your mouth out with some salt water first, and then I'll tell you how to deal with that a little later. But you're going to put it in their mouth and have them to swish as long as they can. But if they have raw areas inside the mouth, because that sucralfate sticks to the protein. It doesn't destroy the protein like peroxide does. It sticks to it and it protects it. And so then if you have it, if it's in your throat or your esophagus, you swallow it down, and as it goes down, it sticks to the throat and esophagus areas that are raw as well. So that's a really good thing. And you don't want to drink anything after that. If it's right before, like 30 minutes before a meal, you want to have your best condition anyway of your mouth and your throat and your esophagus. So you want to do that 30 minutes ahead of time, and don't drink anything until it's time to have your breakfast or your lunch or your supper. And then you can swallow a little bit easier. And now we have a liquid form that's for the Carafate. In the head and neck cancers, you often have to get a PEG tube. It's a tube that goes directly into the stomach, just through the skin, for tube feeding until it's healed for radiation therapy and chemotherapy patients. And it can take months to recover. So some people are not well nourished enough until they can heal up. It takes a while, and the salivation and the taste might never fully recover. So zinc supplements can help with taste restoration. And we did have a patient one time that had, she had, I think it was esophageal cancer or stomach cancer, but she had radiation in those areas, and she just refused to do a PEG tube. And then she finally was having all these problems, and she ended up having beriberi. That's a vitamin deficiency. It's a B vitamin deficiency, but she couldn't absorb it, or what she did eat, and she wasn't eating hardly anything. So she finally got her PEG tube, and got well nourished. But that was weird. I had never heard of anybody in our practice anyway having beriberi except her, because she refused the peg tube. She just thought she would just soldier right through it. Okay, so I will stop now. I know we've got so much other stuff to cover. I just did not want to get too rushed for Wednesday. So let me get off of the stop share and let's stop the recording. And okay, let me see what we got on our. Basically, differentiated means they have a purpose and function, and they're not just dividing just to divide. And undifferentiated means that they have no purpose and they're just dividing, which is abnormal, meaning cancer. Yeah, yes, that's what cancers do. That's Alicia. Basically, wait a minute. Oh, I guess it went on there twice, didn't it? Oh, you went to me and to them. Okay. Yeah, those are they're just dividing because signals are wrong. That's the deal, and that's the sort of the beauty of this now, that we're learning what actually turns things on and turns things off, instead of just targeting the cell. It's got to be what messages are being sent to the cell, and some of the messages are within the cell. So anyway, that's where the targeted therapies come in. And we still don't know a whole lot about it, but boy, they're coming out like crazy. And when you see the MAB, monoclonal antibodies, and they're doing monoclonal antibodies to President Trump to fight that COVID infection. So monoclonal antibodies are targeting a specific messenger, I guess, for inflammation or whatever. I'm not really sure what that is, but anyway, it's targeted, and it's I think it's experimental, but it has worked for some other people, so they're taking every chance they can to get him better. But that's not a cancer thing. But see, the cancer research has let it be, like an infectious disease research project as well. You can target infections and you can target autoimmune problems. So it's really blossoming out, and lots of research has gone on for so long, and finally it's come into fruition, and hopefully people will be able to afford their stuff, though it's very expensive. So anyway, okay. Does anybody else have questions?
I have a question, Ms. Beaver. I haven't went over it yet, but I'm just trying to study it very effectively here. With the medications, I'm looking at the meds on my PowerPoint, and I'm looking at the meds that you have for your notes. Do you want us to know the mechanism of action for the medications, the side effects for the medications? What am I really studying here for the meds?
Yeah, you really do need to know what those particular ones do. Yeah, that's the one on like the practice problem sheet on the back, and then there are some in the it's with the chemotherapy stuff. Yeah, we've got that nitrogen mustard and interferon and tamoxifen and Herceptin. And I did have on your sheet or on your blackboard that you need to know about that ondansetron and the I think what the other one was. Oh, it was zoledronic acid. So those are some things that you need to know what they do and what are some side effects, and especially for that cyclophosphamide. Nitrogen mustard and cyclophosphamide are of course very similar, because nitrogen mustard started out, and then the Cytoxan was sort of a result of that. It's they messed with the formula a little bit, so it's not quite as toxic. But then it does. They still can use it in Hodgkin's disease. Sometimes they will, but they're trying not to have such toxic ones if it's all possible. So but yeah, cytoxin is an irritant, and nitrogen mustard's a vesicant where it eats away at your hands or your arms. But yeah, you do need to know what I have on, listed on the on my page there, and on those practice problems.
Right. There's a sheet that has the chemo classifications. It's like a lot of them.
Oh, so what you've got? Let me see if I've got the Herceptin thing. Yeah, the cytoxin is on there, cyclophosphamide's on there, and the tamoxifen is on there, and interferon is on there. And Herceptin is on like the next page, and it has a picture of normal HER2. It's human epidermoid receptor 2, whatever, and then so we just call it HER2. But if you have a little bit, you're supposed to have a little bit of HER2, but then it has like 5 or 6 times as much on the picture, and so that's where you got cancers, is that it's stimulating growth and cell division of the cancer. So yeah, that Herceptin is where is on there, and I've got it on the PowerPoint notes page also. So that's the kind of stuff I want you to know is what I have on there. And you don't have to have the rest of them, because there's just loads and loads and loads of chemotherapy.
Yeah, it is. I'm like, oh, what world am I looking at? What am I not supposed to look at? Like the chemotherapy classification groups. I'm like, is that for us or?
Oh, I know. Don't. Yeah, that's what I told y'all at the beginning. I'll tell you what I want you to know then. And
Okay, yeah,
and so it is on that one sheet, and yeah. So it's really a resource sheet. And because I did that a long time ago for RCCC when I was working at the oncology clinic in Salisbury, and I did that for that particular incident, and I've updated it some too, but yeah, it's just a resource, because you can't. I don't remember all of that. I can't do it. I have to know where to look it up. So, but yeah, I do want you to know those basic ones though that are in those particular categories. So, you've got your cytotoxic medication, you've got your biologic, you've got your hormonal, which is the tamoxifen, and Herceptin is a targeted. And then you've got an antiemetic, which is the ondansetron, and yeah, that's, let's see, ondansetron, and then the zoledronic acid. Zometa is the brand name, but zoledronic acid is the generic name. We're really supposed to go into the generic, but I kind of like to, I like to on my test, if I'm giving you a drug name, I'll give you the generic name first, and then put the brand name. But Ms. Walker doesn't want us to do that on the exam, so hopefully I won't have to change it on my test, but on the exam she's wiping out all of the brand names. So you got to get, you have to have the, I'm warning you about that, but because she changed mine. And I can understand that, because you really do need to know your generic names, but I think at the first it's a lot better for you to know, like if you're asking your patient what you're taking at home and they say Lasix and you don't know what it is, because you're only learning furosemide and you don't know the brand name. So I guess you can look it up easily though on Google, but yeah, that's a warning. You've got to look at your generics.
Thank you.
All right, y'all all set to go?
Yes, ma'am.
So loud out of my window. So, all right. Well, I'm gonna head on out if y'all are okay.
Yes, ma'am.